Hello, everybody. My name is Hermann Einsele. I'm based in Würzburg in Germany, and I'm the director of the Department of Internal Medicine, where we run a large myeloma and immunotherapy program. Now, it's my great pleasure also on behalf of my co-authors to present a study that we presented at the last ASCO meeting in Chicago. And the title of this presentation was Biological Correlative Analysis and Updated Clinical Data of Cilta-Cabtagene autoleucel, CILTA-Cel, a BCMA-directed CAR-T cell therapy in lenalidomide-refractory patients with progressive multiple myeloma after 1 to 3 prior lines of therapy, the so-called CARTITUDE-2 study Cohort A. So what is the background of this trial? Patients who have progressive multiple myeloma after 1 to 3 lines of treatment and are refractory to lenalidomide or PIs have limited treatment options. CILTA-Cel is a CAR-T cell therapy expressing 2 BCMA targeting single domain antibodies designed to confer high avidity. CILTA-Cel was recently approved by the US FDA administration for the treatment of adult patients with relapsed refractory multiple myeloma after at least 4 lines of prior therapy, including an PI, an IMiD, and an anti-CD38 monoclonal antibody. The European Medicine Agency has recommended CILTA-Cel for authorization in a similar indication, but in patients with at least 3 prior lines of therapy. Now, in the CARTITUDE-2 study, CILTA-Cel is now or was evaluated in patients with multiple myeloma in earlier lines of therapy. So the CARTITUDE-2 Cohort A consists of patients who are lenalidomide refractory with 1 to 3 prior lines of therapy. In this study that we presented in Chicago at the last ASH meeting, a second update was reported after median follow-up of 71 months. So the study population were 20 patients. 1 patient was treated in an outpatient setting, and the efficacy of the study was an overall response rate of 95%. 85% of patients achieved a stringent complete remission. 90% achieved a complete remission, and 95% achieved at least a very good partial remission, so an extremely high response rate. Median time to first and best response was already after 1 month, and the median duration of response was not reached. Actually, the estimated 90% of responders remained in response for now already 12 months. And the 15 months progression-free survival rate was 70%. So really looks like long-lasting responses in these already quite heavily pretreated patients. Now, what about safety? CILTA-Cel's safety was manageable and predictable. The incidence of initial grade 3/4 cytopenias not recovered to grade 2 by day 60 was 20% for neutropenia and 50% for thrombocytopenia and 5% for lymphopenia. So it looks like that the earlier application of a BCMA-directed CAR-T cell product is associated with a lower incidence of severe cytopenias. The other issue was cytokine release syndrome and neurotoxicity. So there was some fear that by earlier application of fitter T cells, we might end up with a higher CRS. And fortunately enough, this was not the case. 95% of patients developed a cytokine release syndrome, but only 10% had a grade 3 to 4 event. And the median time to onset was 7 days and the median duration 3 days. And tocilizumab was administered in 70% of patients. The other issue was neurotoxicity, the so-called ICANS, and only 3 patients had an ICANS, which was grade 1 in 1 and grade 2 in 2 patients. The median onset was after 8 days and the median duration again 3 days. There were no cases of movement and neurocognitive treatment emergent adverse events that have been seen in a few patients in the CARTITUDE-1 trial. And so the incidence of Parkinsonism decreased following implementation of major patient management strategies across the CARTITUDE program, which included early intervention if there is a high persistence and a high peak of CAR-T cells, and a better bridging therapy in patients with a high tumor load. 4 deaths occurred, 1 due to COVID, 1 due to sepsis, and 2 to progressive disease. And correlative analysis showed that CAR-T cell expansion and median that CAR-T cell expansion occurred on day 11. Median persistence was 153 days, so rather short. Levels of IL-6, interferon gamma, interleukin-2 receptor alpha, and IL-10 increased post-infusion, peaked at days 7 to 14, and returned to baseline levels within 2 to 3 months post-infusion. Cytokines and CD4-CD8 ratio with respect to CRS and ICANS, so higher IL-6 levels were associated with higher severity of CRS. This was already observed in other studies, and the same applied to other cytokines. And there was also a trend of increasing CD4 CARs to CD8 CAR T cell ratio associated with CRS and ICANS. High overall response rate was also correlated with cytokine levels and response, and there was no association of CD8 enrichment with response at peak CAR T cell expansion. So in summary, the Cilta-Cel treated patients who had received a median of 2 prior lines of therapy and were lenalidomide-refractory had an overall response rate of 95%, with 90% achieving a complete remission or better. So really extremely high response rate in these already pre-treated patients. The safety profile was manageable and predictable, including the patient treated in an outpatient setting. CAR-T cells had a median persistence of 153 days. And this patient population included in the CARTITUDE-2 Cohort A is also being investigated in a phase 3 trial in which Cilta-Cel is compared to PVD or DARA-PD. Thanks so much.